What I'd like to do now is just do a brief review of the Breast Health Global Initiative and how we got to this particular place so that we're all starting from the same common ground. Breast Health Global Initiative was started in 2002, and the goal is to develop, implement, and study evidence-based, economically feasible, and culturally appropriate guidelines for international breast health care and cancer control for low and middle income countries, with the ultimate goal of improving breast health outcome. We originally focused on this, recognizing that limited resources are one of the major issues that prevents breast health care from being delivered in a proper fashion. But it's important to recognize that limited resources come in many forms. We typically talk about financial constraints as being the major obstacle, and certainly limited finances is a major issue. But it's significantly more complex than that. And some of the obstacles actually are not financial in their nature. Organizational dysfunction is a common problem and certainly not restricted to low and middle income countries. And also a major issue is inadequate human resources. Even if we have all of the tools and the money, if we don't have the proper training and the personnel operating in a functional fashion, we will have great difficulty delivering health care. That, of course, is not restricted to breast disease, but is throughout health care in its nature. What I'd like to do then is talk about the resource stratified guidelines and how we got to this particular place. This is the 4th Global Summit, and the way that we've operated all of them, including this one, is pulling together groups of experts from around the world to review the available information, much of which does not come from low and middle income countries, but to assess how does this actually apply in the setting? What is biologically based and should be universal? And as we were talking about earlier, the outcome of each of the summits was the publications that resulted from this. Our first Global Summit publication was a supplement in the Breast Journal and focused on healthcare disparities from our 2002 summit in Seattle. The second summit in 2005 focused on resource stratification, that the idea that there are some resources that are more necessary than others, and this is part of designing a system. Our most recent global summit in Budapest focused on guideline implementation, and here we are today to ask the question, how do we move into actual healthcare delivery? From the Breast Health Global Initiative standpoint, this is a turning point for us, where we are moving from a phase of theoretical work, that how should this work, to actually applied projects that will be developed during the course of this conference. In that first summit, the healthcare disparities concept was, let's look at what the issues are. And certainly everyone recognizes that primary prevention is ideal for cancers. That is easy when we talk about tobacco-related cancers, because by removing tobacco, one could have a major impact on that outcome. We don't have a tobacco analog for breast disease and breast cancer. There are a series of low-level risk factors, many of which are linked to reproductive health, that seem to promote breast cancer, and it's the reason that it is the most common cancer among women around the globe. So if we can't primarily prevent it, at least not for the great fraction of these cancers, we need to go through a system of early detection, diagnosis, and treatment, because that's the sequence that we know improves outcome. And so in that first global summit, we identified the global disparities in each of those 3 areas. In the second Global Summit, hosted by the NCI Office of International Affairs, Joe Harford's group, who's been one of our great sponsors since then, we developed this concept of resource stratification, this recognition that some resources are more critical than others, and we can actually put them in an order as we design systems. And we also recognized that looking at the healthcare systems themselves is part of this discussion. Because even if we know how to do early detection, diagnosis, and treatment, it has to exist within a delivery system that can support it. And there are going to be features that will either be supportive or not supportive, and that was the point in those analyses. The third Global Summit in Budapest resulted in this cancer supplement publication. And this really is the culmination of the 3 global summits. You have the overview article from this publication in your booklet. And what we did was put together essentially the observations of these 3 into this completed document looking at those at the resource stratification. And what we developed, the hub of this work, are these tables. And I anticipate that we'll be referring to these tables as we continue our discussion. So in each area, healthcare systems, early detection, diagnosis, and treatment by stage, all of the standard therapies that have been used are listed and put in order. There are 4 categories of these resource stratification, and we will continue to use these same definitions. So this is in your handout. Basic level resources are resources you cannot do without. Basic level resources would include surgery, because if we can't operate on breast cancer, we cannot treat the local disease. Limited level resources, the next level up, are resources that have been demonstrated through prospective randomized trials to make major improvements in survival. Many drug therapies fit in that limited level category, that we know if we can bring this piece in, that we can anticipate major improvements in survival. The enhanced level resources, the 3rd tier down, enhanced level resources are those resources that may not necessarily improve survival, but improve options. So, for example, breast conservation therapy, a lumpectomy with radiation. A woman doesn't live longer because her breast is conserved with a lumpectomy and radiation, but it is an option that makes therapy considerably more acceptable when it is a feasible thing to do. The last group, and this is a really key concept that helps us not get bound down in our concepts, maximal level resources are the highest level resources. Highest in the sense that they're the most expensive, they may be the most technically demanding, they tend to be things that we focus on in meetings like ASCO or San Antonio, these new developments. But if you ask, how many lives do you save by bringing this tool in, the answer may be 0. So as an example, PET scanning is a very valuable tool. Many high-end centers use PET scanning for looking for disease throughout the body, but if you ask how many lives are saved by PET scans, the answer is likely going to be 0, and that's something to help guide not what to implement. So do you see that in this framework, it allows us to do gap analysis, to figure out where are the missing pieces that we need to fill.